Well, happy Friday to everybody out there in SADS Facebook Live land. I'm Mike Ackerman, and on my right or my left is
There you
not
go.
Dr. Arthur Wilda. It is our CEO and president of the SADS Foundation, Lara, who's joining me today. And unfortunately, Arthur Wilda from Amsterdam, Netherlands, who is a dear friend of mine, had to take care of an urgent matter at his hospital. And so he's not able to join us, but we will get him here because he and his research team just published earlier this week in the journal Heart Rhythm a very important paper that literally answers so many of the questions that families with genetic heart rhythm diseases, our channelopathies like long QT syndrome and Brugada syndrome, have been posing to us at the SADS Foundation for the past 2 weeks. And so his team put an urgent paper of guidance together for providers and physicians who take care of our families with the channelopathies. So I wish he could be here to join us and cover the highlights. I'll do my best, and Alice will, together, we'll try to answer your questions as best we can. We are well in the midst, as you know, of the COVID-19 pandemic. And so wherever you're at, we wish you well. We hope you're doing all the things to protect yourselves and your families, as all of us are supposed to be doing. And the statistics right now are, of course, sobering. We just crossed the 1 million mark for cases of COVID-19. There's probably many more coronaviral infections that have gone undetected and unrecognized because they're asymptomatic. We will soon be approaching 56,000 deaths worldwide. In the United States, of those million cases, 257,000 come from the United States, and there have been now 6,586 deaths. That translates right now into a case fatality rate of 2.6%, which, as we all know, is much higher than that of influenza. And so we need to be doing all the things to protect ourselves. My temperature was 97.7 Fahrenheit. Alice, I don't know what yours was today.
I did not take mine today, but I do have a thermometer. I'm ready to. I did not take it.
She's going to set a good example for all of us, and like all of us, taking our temperature at least once a day.
Okay, but I am washing my hands. I'm washing my hands.
That's great. Here at Mayo, we're required to take our temperature morning and evening and not come into work if it registers 100.5 on the Fahrenheit scale. So we all do our part. And I love one of my families who has embraced my hashtag refuse to fear. And we at SADS, we too refuse to fear. Knowledge is power. And so let's see what your questions are. And I'll try to weave it in the answers with some of the highlights that Dr. Wilda and his colleagues wrote about in the journal Heart Rhythm. You can get to it online yourself and read and download this very important paper. So I'm going to glance to the side. Before I do, some of you are wondering, I know you are, so I'm going to show you. This is my granddaughter, Jaden Ruby Lorraine, and she's 66 days old today. I've last seen her in person when she was 21 days old, so we miss her. We were supposed to be out there twice, but that was BC, before Corona. So it's a different time. So I'm going to look up and see the questions, and they're coming on in.
The host one, Mike, is one that we have that was asked, is there a drug we can substitute for Zantac that was pulled this week? We have for long QT family members.
Yeah, that's so Zantac, as some of you know, is a sort of a medication used for reflux, heartburn, indigestion, and Zantac generic ranitidine, I think, is the generic it's been pulled. It's on the hit list. Honestly, that medication, as with all of the heartburn medications that are available over the counter, where you don't even need a prescription, the QT signal behind them is incredibly weak. And so that person who asked the question even mentioned a doctor prescribed Pepcid. Well, that's actually, it was me, because I received a question from one of my patients out there about the Zantac issue, and I suggested to my nurse to offer Pepcid as an alternative. They're on the list. Their strength on the list is incredibly weak. And we'll probably talk about that over time, that not everything that's on the www.qtdrugs.org list is equally dangerous. Many of them are actually quite safe. And the over-the-counter heartburn medicines like Zantac and Pepcid are really safe. So I'm completely comfortable having my long QT patient take Pepcid.
So we have another one that that came from someone overseas, and we have a number of people from other countries joining us today. They wanted to know about recommendations from this paper. Is it going to be shared with European colleagues and the cardiologists in Europe?
From our paper or from
Dr. Vilda's paper that was just
so that paper is available worldwide. So as I mentioned, it came online in the journal Heart Rhythm, which is one of our leading heart rhythm journals in the world. And they published it fast track, and the editor and the publisher has made it available without access. So you should be able to search it and find it. And otherwise, you can reach out to us at SADS Foundation and we can send you the link. I don't have the link.
It's on our website, actually. It's the link is, so that's great. But it's free. It's free for anyone to use. Yep.
Yeah, it's free access. And I think with some of the questions coming in, we'll be able to answer some of the highlights that are in Dr. Wilda's paper.
Mm-hmm. There's one on cardiomyopathy, and the next one that I see, young adults with cardiomyopathy.
Yeah, so I mean, what's come out there is that patients with heart disease are at higher risk. We said starting 2 weeks ago, yes, but that's not my patients. That's not patients with long QT syndrome. So patients with long QT syndrome, patients with a CPVT, patients with Brugada syndrome, there's no great evidence at all that our patients are at greater risk. In fact, I don't yet have a single patient with long QT syndrome of the more than 1,400 that I have the privilege of taking care of that have come down or have informed us that they have COVID-19. So they're not, and if they do, their risk isn't going to be any greater than any other 10-year-old, 20-year-old, 40-year-old. As we get older, and if we're older than 65, we have greater risk by virtue of our age, not by virtue of the presence of long QT syndrome. Now, what's different in that discussion is not all genetic heart diseases are created equal. So we're going to try to have our colleagues from Johns Hopkins join us in one of the next weeks to talk specifically about a different genetic heart disease, that of a genetic heart muscle disease called arrhythmogenic cardiomyopathy, or ARVC. There we have concerns that potentially if the virus, if we get coronavirus infection, that viral infection, if it infects the heart muscle, which we know it can do, can be more agitating and aggravating to a heart that is an ARVC heart than a heart that is a long QT syndrome heart. And so it's not going to be a one size fits all where the risk is the same for everyone. Risk is very low, the same as for me by long QT syndrome. The risk is higher for our patients who have genetic heart muscle diseases like ARVC, like dilated cardiomyopathy, and perhaps even hypertrophic cardiomyopathy.
That's great. Yeah.
Did you see another one, Alice?
Yeah, I think there's just one about fever with the COVID fever. Is that a separate risk?
Yeah, so that's a great question because, right, fever is fever, whether it's coronaviral fever or influenza fever or whatever fever. And as Dr. Wilda points out in their paper, for families with inherited arrhythmia syndromes like Brugada syndrome, where we know that countering fever is one of our important countermeasures for Brugada patients, no matter the source of the fever. And coronavirus is no different. If we get fever from coronavirus and we have Brugada syndrome, we should quickly, promptly lower the fever. And in the case of coronavirus, probably the antipyretic or the fever reducing medicine of choice is Tylenol, acetaminophen, rather than ibuprofen. Long QT patients who get fever, we should probably lower fever. There's weaker evidence that fever can be long QT agitating in long QT. We know it's agitating in Brugada syndrome, and that's why it's most important for our Brugada patients who get fever from whatever source to lower their body temperature as quickly and as best they can.
And I think there's another question. Danielle poses a question, and I know some others have as well, concerned about whether they go into care with COVID, they're going to be seen. Do they immediately try to find their primary care physician or their EP doctor so that they can recommend?
Yeah, that's great, Danielle. And so I think Danielle is the one who sent me a beautiful picture of the hashtag refuse to fear. And so Danielle, love you and love your daughter. So I think that's a really good question. What we have told our long QT patients is that if they get coronavirus infected and if they're symptomatic, so by definition, coronavirus infection that leads to symptoms is now called COVID-19. That's the name of the disease when the virus makes us symptomatic. And if our doctors are then starting to think about adding medications or using medications with known QT prolonging potential, like hydroxychloroquine and like azithromycin, medicines that we all have probably heard of now, then that should be done in consultation and discussion with your healthcare provider. Now, if by chance the COVID-19 in our long QT patient is bad, and we're admitted to the hospital and we're in intensive care unit and we don't have time to be thoughtful and think through it, then you will be monitored. And if the decision is made to treat you or give you hydroxychloroquine, then the monitoring needs to be done very carefully. And that's also covered in Arthur Wilda's paper, where although long QT patients were not at greater risk of disease expression, but if we do get COVID-19, right now, one of the main treatments that's being used is hydroxychloroquine, in combination often with the antibiotic azithromycin, for which you all know we've been encouraged you to say, try to avoid the Z-Pak, Zithromax. And now potentially a long QT patient could get both medicines. And so there we have to just be incredibly careful. Those medicines are not off limits to you. They just need to be done very carefully. They will be off limits to some long QT patients if their long QT disease is bad enough. So example, if your QTC is in the red light, we called it, and at 500 milliseconds or more, stop. They better not add both at the same time. They should start with hydroxychloroquine, and that's only if they think our backs are up against the wall, we've got to do something, and this is the best something that we know how to do right now. So it's really going to be a risk-benefit calculus for each and every patient, where we try to decide what's in the best interest of that patient, and does it make sense for our long QT patient to get placed on a treatment where that treatment itself could be potentially dangerous to the long QT heart. So it's going to be a very careful balancing act, but we can do it. We can do it if we need to.
And I think that that's great. And the next one is kids with CPBT. Are they more risk if they get COVID?
So Sharon, thanks for that question. I think like long QT syndrome, there's no data that a patient with CPVT is greater than is at greater risk of COVID-19 than the same patient at the same age who has no heart disease. The one potential nuance there is, when we get a fever, our adrenaline can rise, our heart rate can rise. And again, trying to lower the fever to blunt the sort of adrenaline reaction that can sometimes come with febrile illnesses is probably just a good thing to do. But we're not seeing any signal so far or any reason why the coronavirus would be more agitating to somebody with CPVT.
And then I think that Michelle Berg has one that's asking about a device. If they have an ICD, is that more dangerous for your heart if you get COVID? Is that something to worry about?
So Michelle, thank you. That usually means that their long QT or your CPVT or your Brugada syndrome has already been bad enough, or we are worried that it's already telling us to add more protection by adding an implantable cardioverter defibrillator or an ICD. But that just means that's where your long QT is at, or your CPVT is at in terms of its risk category. It doesn't mean that the coronavirus infection would necessarily misbehave with that long QT heart any differently than it would with a long QT heart where you've never ever had a symptom and your ECG is normal. So it probably does mean, and oftentimes, that your QTC is longer than other patients. And so that means if we needed to treat you with a medication that's on the QT drug hit list, like hydroxychloroquine, that we need to be minding our A, Bs, and Cs very, very carefully so that the combination doesn't rear its head in terms of a treatment side effect or a treatment complication.
Right. And then Brittany's asking about Bear and Timothy syndrome. His is always over 500 QTC.
Yeah. So Brittany and Bear, hello to you. My third son, we call him Gen Z Bear. We named him that at birth, and he's a Baylor Bear at Baylor University, but of course on home study. But to the question, many Timothy syndrome patients, their resting QTC is above 500, whereas our long QT patients, in my entire program, only 15% of my long QT patients are above 500. And so it doesn't mean that you can't have hydroxychloroquine if Bear were to get coronavirus infected and had COVID-19. It just really depends on what's the status of the disease. So if the illness is mild, like it's mild in 80% of all of us. So if we got coronavirus infected and we were called Timothy syndrome, well, 80 to 85% of all Timothy syndrome's coronavirus infection ought to be mild. That's good. And so if it's mild, we shouldn't treat mild symptoms with hydroxychloroquine when the QTC is above 500. On the other hand, let's say we had bad COVID-19 and we're now hospitalized and we're now thinking about needing to get intubated. Not that you're thinking about it, but we, the healthcare providers, are thinking that we might have to do it. In that context, then I would be more willing to say, all things considered, let's try hydroxychloroquine, especially if the data comes out in the next days and weeks that it actually is really beneficial, where we actually don't know that answer to my satisfaction yet about how much benefit or efficacy is that medication. So really, Brittany, for Bear and for every patient with COVID-19, it will depend on when they get it, how bad do they get it, how good is the efficacy signal with hydroxychloroquine that we learn about, know about by the time they get it, to then decide, do we use it? Asymptomatic, trivial symptoms, no way, don't use it. Bad COVID-19, then we might go ahead and use it if we see that the signal of efficacy is good, and then we'll take our countermeasures to try to make the risk of a drug reaction as minimal as we can.
That's great. I think there's also one about Nadolol and a cough. Obviously, any cough is concerning right now. Everybody worries about that. I know with us, it's fire. I mean, it's the all the trees are in bloom and causing allergies. Right. So that's an issue too.
Yeah, Courtney, that's a great question too. And the Nadolol you started a few months ago, I would say that the data that Nadolol is triggering a cough is really, really weak. So it would be hard for me to blame the cough on Nadolol. Now, having said that, that doesn't mean you have COVID-19 and coronavirus. In fact, I would say some encouraging news out there. We've done over 5,000 coronavirus tests. And I'm just getting a text from Dr. Wilda that he's not able to log in. And so if I could have, Aaron, if you could reach out to him just on the side and tell him we will get him rescheduled for early next week, so I don't break out of this. So anyway, 5,000 coronavirus tests, the nasal swabs. Of those 5,000, we have 100 that are positive. So that's 100 out of 5,000. That's 10 out of 50. So, 100. I got to do that fancy math. That's 1 out of 50. And so that's 2%. So that means all those people who thought they had symptoms went to get the nasal swab, only 2% were positive. So in other words, there's a lot of reasons for a cough right now. And a cough doesn't equal COVID-19. So all things considered, I won't be too concerned at this stage. If you have had connections or contact with people who are proven to be coronavirus positive, then that's a different story. But can't blame the cough on the Nadolol, but not likely statistically that you have coronavirus. Good question. Then Alice, a lot of questions are coming in.
There's a bunch all at once, and so then I lost the one I was thinking about. There's definitely one about a heart block. That's a special case one, but here's one with CPVT and asthma and on atenolol and flecainide. Louisa is asking that question. Is there something worrying her that she should know?
Yeah, I will come back to. I'm just going to quick in real time text Arthur. So Alice, if you want to look at a couple questions while I let him know.
Yeah. Well, and I think there's a few in here. Like I think someone asked about the red, green, and yellow guidelines that Dr. Ackerman has, and they are also on our website and linked to Mayo Clinic. So you can look at those, and your doctor as well. You can look at those, take them to your physician. I think there's, the hospital one, I think that you answered. Yeah. She has lung QT and she works in a hospital and she might not have the best PPE always. And she's worried about whether she should try and be in an area.
So Alice, which question was that?
The PPE, it's Sherry Hiller. You can see it. Healthy 37-year-old with lung QT, working in a hospital.
Oh, I see, yeah.
Because I know that people are talking about high viral loads might make it more likely or more.
Right. Right. Yeah, Sherry, that's, I would say, I wouldn't say your long QT status changes that any different than mine and my potential exposure in that environment. I think we all should be concerned about our personal protection equipment, but that viral load issue isn't different in the person with long QT than in my heart. It is different in the person with arrhythmogenic right ventricular cardiomyopathy or ARVC, and if the appropriate protection measures aren't there, I would be more insistent or encouraging to try to get out of that environment. But long QT, no. So I think do your best. I wish we had all the PPE, and I think solutions are happening to that. But just be by virtue of long QT, you don't have to fear those areas. I think all of us should stay clear of those areas if at all possible.
Great. And then I think there's one from Sarah asking about guidelines, and I think that you can just mention that again, available, because she's coming to see you, her family, in May, but she wants to know in case something happens.
Yes, Sarah. So I look forward to seeing you here, and probably the seeing you in May actually means that we'll be seeing you this way by video consult, because like most medical centers throughout the country, at least in the United States, we have tried to reduce the footprint of patients on campus. And so I just did 2 video consults earlier today. So that's the way that we're doing it right now. And so I'll see you then. But until then, the SADS Foundation website is great resource for you that provides some guidance. Arthur Wilda's paper is great for you that talks specifically, or great to give your primary care physician in that setting. And then the third resource that we spent a lot of time on is what's called the Mayo Clinic Connect page. And that's not just for my patients and families who have already been here. That's for anybody, anywhere in the world, where you can go to Mayo Clinic Connect. And if you were to type that in and Google that, that would come up. And then under pages, you could type in long QT or genetic heart rhythm, and that will take you to the Winland Smith Rice Genetic Heart Rhythm Clinic Connect page. And there, all your answers many of your questions can be answered, including the highlights from Dr. Wilda's paper. And so there's a special section on that Connect page devoted to just all things COVID-19. So hopefully those will be resources that you can avail yourself to, and then give us feedback at the SADS Foundation and at our Mayo Clinic Connect pages. What are we missing? What question have we not yet answered to your satisfaction? What is concerning you, worrying you, so that we can make sure that we attend to that, and that we can devote a future Facebook Live session to those particular questions that we haven't quite answered well enough.
Yeah, that's good. So Jessica is asking about the new Livecore device. Is there something that hospitals now have if they might need them for monitoring?
Yeah, so thanks, Jessica, and I hope you're doing well down there in Florida, and I look forward to seeing Disney World open again, and maybe I can go on a ride with you guys. But, Jessica's asking about a particular device. And so in our guidance for how do we want physicians and healthcare providers to monitor the QTC of anybody who's getting hydroxychloroquine, not just my long QT families, but if I get coronavirus infection and I'm getting admitted, if I had my choice, I would want my team to know what's my QT value, so that I know whether I'm cleared, good to go, green light, safe, a lot of safety margin with the use of a QT prolonging medication like hydroxychloroquine, trade name Plaquenil, or whether my doctors need to take some precautionary measures before they give that to me. So there's really 3 ways that we can know the QTC. We can either see it on the telemetry. So if you're already admitted and you're on a monitor, the healthcare team can look up at the monitor and stare at your QT and quickly determine whether it's in the green light safe category. The second way is the 12-lead ECG, which all of you have had if you are patients, where you know what room you went into, you know what people were hooking on you. But that is not a great solution at this time, because that means somebody wheeling in the 12-lead ECG machine wearing his or her protective gear, being exposed to your coronavirus infected state, and then doing it again after the medicine's been administered a couple days later, 4 days later. So that doesn't sound so good. And there's now because of that, the FDA has fast-tracked approval for not only one now, but at least 2 different mobile device companies to where they can be used as an indication for QTC monitoring. And so Jessica asked about Alivecor, and this is Alivecor's device. It's the KardioMobile 6L, not an advertisement, full disclosure. Mayo Clinic has partnered with Alivecor long before Corona in 2017, where we've been working on trying to create a QT meter. So we have this ability potentially with a smartphone enabled mobile ECG device to be able to get a QTC reading without a technician having to come in and out of the room. So that strategy is starting to be implemented all over the world, and where they're using that way of obtaining a patient's QTC. But if we can't find your QTC, because let's just say, let's get real, at our place right now, that method to get your QTC determined doesn't exist, then what we can all do for all patients is know your QTC risk factors. How's your electrolytes? If not normal, normalize them. How's your health? How's your list of medications that you're on? Are you on any other medications that are already QT prolonging or potentially QT prolonging by themselves? Is there room for a time being to pause on those medications while we add the hydroxychloroquine? So all of these decisions would be taking place with your healthcare team. And so be aware, be respectful of the QTC, take the QTC countermeasures in all of us, know your QTC if we can, and then respect the QTC, as I said, but don't fear it. We can neutralize the side effect threat in almost everyone.
And then Mary's asking a question about antibody treatment. Have you heard that it's being used yet? Is it safer for long QT?
Yeah, Mary, that's a great question. And this is hot off the press. Mayo Clinic and Johns Hopkins and a handful of other sites, as of about an hour ago, were named destination sites for the convalescent antibody therapy. So this is being ramped up throughout the United States. And what Mary's asking about in terms of convalescent plasma therapy is that patients who've already cleared their coronavirus and have resolved their COVID-19, or those who didn't even have COVID-19, but they had coronavirus and their body's immune system already cleared it and generated the antibodies to clear it, we can do plasma donation from those individuals, just like, donating blood. We can donate plasma and take and match and take that plasma therapy with the antibodies in it that already cleared that patient's infection, and give the next patient who's right in the midst of his or her COVID-19 convalescent plasma therapy. So that's becoming and will become another treatment option. It's getting ramped up. I think it's very exciting. The possibility, the potential seems pretty good. And there would be no reason why any of our genetic heart disease patients would necessarily have an adverse reaction to convalescent plasma antibody therapy compared to any other patient. There's always the risk of blood reactions and things like that, but that's a risk that's present in all people. And so that we will learn in real time, and we'll probably have an update next Friday as to what is the state of that particular treatment. So stay tuned. Everything is moving kind of at a dizzying pace.
Yeah,
so
that's true.
Disney World, Jessica, is closed, but we're all on quite a roller coaster, and some of us are pretty dizzy at the moment. But Thanks, Mary.
That's great.
That's a
Good.
really good question, and I'm pretty excited to see where that
Just
treatment
going.
goes. Yeah.
Yeah. There's one earlier one that I skipped, I missed, and that is if you have a mild case and you're just quarantining at home and trying to treat your symptoms, is it safe to use quercetin and cold and flu to treat, or is that going to mask anything? Or if
No,
you have non-QT?
if your symptoms are mild, you can just do mild symptom management. Lower the temperature with acetaminophen. If you're having a cough, suppress the cough with dextromethorphan, Robitussin DM, any of those kind of cough suppressant medications, and do the home remedies. Feeling tight and congested, Vicks Vapor Rub, chicken noodle soup. Put at the door, open the door, take it while you're quarantined. And so all of the home remedies, and that won't mask the recognition of it getting worse in you or not.
Serious.
Yeah.
And then there's a number of those follow-up. Barbara Golly and others are asking about having access to the Alivecor. Should they buy one and bring it in? Is it available in Europe? When is it going to be available in Europe?
Yeah, that kind of a device is available everywhere. You can go on Amazon, I guess, and that's how I ordered mine, for example.
That's how I got mine.
So they are available, and they don't have right now. So like when you put your fingers on it, for example, it doesn't go QTC is 480 yellow light or 500 red light yet. That's what we're working really hard to build into it. So right now, the data is collected. The data is then sent to the cloud where the QTC is measured and reported back to the healthcare team. And so that those steps are being assembled. So the pace is crazy. It's all getting assembled now in, as fast as possible, as opposed to the previous 3 years of our methodical development of the QT monitor.
And there was also a question last week about whether if they already have one that is older, do they need to buy a new one, or is there going to be an software update, or how does it work?
Yeah, the old one that you had, it looked probably like this one, where it's just a single lead that is built into it. And that can work. I mean, your physician can see the trace and look at it and can measure the QT and determine the QTC him or herself. So it absolutely can work, but neither the old one or the new one yet have the brain built into them where it actually reads out the QTC value and codes it with a green, yellow, or red light direction. So there needs to be some analysis that needs to be done with that.
Looks like Brittany's asking about getting one with an ICD. Should they also have an Alivecor device?
No, I think, whether it's the Alivecor or any smart mobile device, I mean, not approved for it, but the Apple Watch can generate the same tracing for which somebody, if they know how to do it, can measure the QT off of it. So for sure, please don't misunderstand. And somebody's asking directly about Alivecor. I don't want it to be an Alivecor infomercial. That's not the situation at all. We are just doing our best to be part of the solution as fast as we can. And do you need it? No, I don't think so. For your particular situation, we know what his QTC is. We already know that we're red light. Frankly, we don't need to know how dark is the red. And so in that particular nuance, I don't need to have a daily Alivecor reading about your QTC. So yours is a little bit different. I personally would save the money and spend the $99 or whatever it is on a dinner when we get to go out to dinner at a restaurant sitting next to people. And won't we love it when that day comes again?
That's great. And I just wanted to take the chance to echo what Dr. Ackerman mentioned earlier, that we would love to know if you have some other questions or suggestions or issues that you want to discuss, because we plan on trying to do these every Friday like this, and having different guests or different issues that we can discuss things. So please let us know either at SADS or on Facebook if you have any ideas. That would be great. And I also wanted to mention that right after this afternoon, we're having our very first heart-to-heart, SADS heart-to-heart. So it's going to be a chat on Zoom, so that you can see each other and just talk about what's happening, how are things going, or how are you coping, and decide on, hopefully meeting every day every week at that point as well, and talk about different issues, and maybe have guests in sort of a small group chat, face-to-face sort of thing on Zoom. So I just wanted to mention that.
And Alice, thanks to your team for doing this. I mean, you guys at SADS Foundation are doing a wonderful job. You all out there in Facebook Live land, you're doing a great job. So stay strong. We're coming to the top of the hour where I have to jump off and do another interview. So I'm going to be leaving you, but I promise Dr. Arthur Wilda sends his regrets. He has been emailing me now saying, I wish I could have gotten back in time. And so we won't keep him until next Friday. We'll figure out when we can do a one earlier in the week next week. We have a great guest lined up for next Friday. You'll enjoy that. We'll get to some of your questions that we didn't, as well as some of the new ones. Let us know at the SADS Foundation what we can be doing to meet your needs. Reach out and Google Mayo Clinic Connect so that you can get connected in that way. The SADS Foundation and us at Mayo Clinic Connect have cross-linked each other so that you can go back and forth to get all of your needs addressed. So stay strong, keep doing what I'm doing and what my children and my wife are doing. We're keeping away from other people, staying close to each other. 6-foot rule, that's 2 meters in those places that think about that. Take your temperature, 100 degrees, 100.5, don't go to work. That's what we're doing at Mayo. I think 100.5 must be around 38.1 on the Celsius scale. Wash your hands a lot. Soap destroys this virus. So soap and hot water is the best antiviral medication we have right now. If you don't have soap and you're using alcohol solutions, it needs to have 60% alcohol in it. And if you're going to the grocery store, I would strongly advise, if you're going to a grocery store, put on a mask, wear disposable gloves, and then take them off. Our most common point of contact for potential exposure, now that we're all distancing ourselves, is going to be places like grocery stores and places like gas stations, with who we don't know who last touched that pump handle. So do all the things that we all can control. Follow the mine and one of my favorite patients. You're all my favorite, but one of them, refuse to fear. Remember, we're all in this together, and stay strong. And Alice and I and Arthur Wilda look forward to you early next week. So take care, everybody. Have a great weekend, and we'll see you next week.
Thanks, everybody. Bye-bye.
Bye now.